So, good evening everyone. Let us start the discussion. Today we are going to discuss almost 80 to 90 of MCQ. So, I hope I am audible and visible to everyone. Just say me hi if I am audible as well as visible. Yes, doctor, tell me, am I audible and visible? Everything fine? Okay, starting with question number 1. The tendency for blood flow to be turbulent is increased by. Yes, tell me. The tendency for blood flow to be turbulent is increased by increased viscosity, increased hematocrit, partial occlusion of the blood vessel, or decreased velocity of the blood flow. So, what is your answer? Please tell me. I hope many of you have given this ELITE test. Even if you are not given, no problem. We will do accordingly. So, what is the answer? If fluid is turbulent, see, fluid can be laminar. Fluid can be laminar also, and fluid can be turbulent also. You know that. Depending on the Reynolds number, isn't it? So, Reynolds number, if less than 2000, chances are that fluid is laminar. If it is more than 2000 to 3000, fluid is turbulent. You know this? Yes or no? And Reynolds number is increased by the velocity. More is the velocity, more will be the Reynolds number, and more is the chance of fluid being turbulent. So, if velocity is more, not less, okay, and number 2, more is the viscosity, lesser will be the Reynolds number. So, Reynolds number, you can say, is proportional to velocity upon viscosity. So, if viscosity is more, Reynolds number will be more, isn't it? And fluid will be, if viscosity is more, Reynolds number will be less and fluid will be laminar. That is why in anemia, what happened in anemia? In anemia, you have seen, Namaste Karan Jaswal, Namaste everyone. So, in anemia, you have seen that viscosity is less, and when viscosity is less, Reynolds number will be more and fluid will be turbulent. This is the reason you get murmur in anemia. So, increased viscosity, no, it should be decreased viscosity. Increased hematocrit, no. Partial occlusion of the blood vessel, yes, you are absolutely correct. Answer is C. When you occlude the blood vessel, velocity will be more, and when velocity is more, Reynolds number is more and fluid will be turbulent. So, answer will be C. Okay, answer will be C. Next question is about regulation of blood pressure. These questions are very, very important clinically also and for your exam also. A 66-year-old man who had sympathectomy experienced a greater than normal fall in the BP upon standing up. So, when you stand up, normally BP does not fall. If it fall, it becomes normal because of maintenance by the baroreceptor, chemoreceptor and CNS ischemic reflex. But in this patient, if you see in this patient, there is greater than normal fall. If someone stand up, there is greater than normal fall. What can be the explanation? Yes, tell me. What can be the explanation? An exaggerated response of RAS. RAS is overacting. A suppressed response of the RAS. RAS is inhibited. Exaggerated response of the baro or suppressed response of the baroreceptor. Just tell me the answer. What do you think? If you are in supine position, suddenly if you stand up, blood will pool in the leg. Who will work? First of all, you know that. Tell me, baroreceptor will start working. Immediate regulation of BP. After that, who will work? Chemoreceptor will work. After chemo, who will work? CNS ischemic reflex. So if someone is standing from the supine position, if someone is standing from the supine position, BP will fall, but who will immediately bring BP normal? Baroreceptor. So if BP is not coming normal, what does this mean? It means your baroreceptors are not working properly. It will work from which range? 70 mm Hg to 150 mm of Hg. Chemo will work from 60 up to 30. If it becomes less than 30, then CNS ischemic reflux will happen. So if you are standing and your BP falls, what does this mean? Baro are not working properly. Why? Because of sympathectomy. You know, if BP is low, baro will stimulate vasomotor center. Baro is going to stimulate vasomotor center, that is sympathetic circulation. So if it is not working properly, your BP is not maintained. Am I clear? See, RAS is the long-term maintenance of BP, not the immediate. Immediately, blood pressure is maintained by the baroreceptor. So if BP is not maintained, it is absolutely clear that baroreceptors are not working properly. So answer will be suppressed response of the baroreceptor. Yes, you are correct. Answer is D. Very good. Most of you are giving right answer. Now, very simple question, but very important. The ventricles are completely depolarized during which isoelectric portion of ECG? Ventricles are completely depolarized after which isoelectric portion of the ECG? What is your answer? Please everyone try to answer. Even if you are wrong, no problem. Even if you are wrong, there is absolutely no problem. Yes. What is the answer? PR interval, QRS complex, QT interval or ST segment. What is your answer? At which isoelectric portion of the ECG ventricles are completely depolarized? Yes, Danish, PR interval, okay. So let me make the diagram also. P wave, P wave, QRS and T. Yes, what is the answer? A, PR interval, ST segment. Danish, ST segment. Okay. Any other answer? Yes, Karan, A. A is what? PR interval, okay. ST segment, okay. What is the correct answer? Anyone? Most of you might be thinking that ventricles are depolarized in QRS complex. Yes or no? Most of you think na that atrial depolarization is P wave, ventricular depolarization is QRS interval. Is it so? But question is what? Ventricles are completely depolarized during which isoelectric portion. What is isoelectric line? The straight line is called as isoelectric line. QRS will be the correct answer. But questioner is playing your game. He is asking the isoelectric portion. And this is ST segment. This is ST segment. After QRS come what? ST segment. So otherwise answer would have been QRS interval, QRS complex. But because they are asking for isoelectric portion, the answer will be ST. See, there are three words: wave, segment and interval. P is a wave, QRS is a wave, T is a wave. PR segment is a straight line, S for segment, S for straight line. So PR is a segment and ST is a segment. Interval means wave plus segment. When I say PR interval, it simply means P wave plus PR segment. When I say interval, QT interval, it means QRS complex and T wave. Yes or no? But they are asking about isoelectric portion, meaning by they are asking about the segment. And segment here is ST segment. Segment is ST segment. Am I clear? So answer would have been QRS. But because peculiarly they are asking about isoelectric segment, this is ST segment. Am I clear? Okay. Next question. In which of the following situation is pulmonary blood flow greater than aortic blood flow? Very, very simple basic question. Very simple, very basic question. Everyone can answer. In which condition pulmonary blood flow is greater than aortic blood flow? There can be only one condition. What is that? Anyone? In which condition this blood, see, normally both are equal. The pulmonary circulation and the systemic both are equal. It has to come back like this only. But what can be the condition when pulmonary, the blood going to the lung is more? Yes, very good. Left to right shunt. If due to any reason blood is coming from left segment to the right segment, more blood will come in the pulmonary circulation. Very simple question. Yes or no? So, the only condition in which blood going to the lung is more is your left to right shunt. Am I clear? Next question. Now, this is a beautiful diagram. Nowadays, for last 10 years, almost every year somehow or the other they are asking this question. Okay, this is a very simple, this is amalgamation of two images. See, this is your Frank-Starling law. If you put here cardiac output and end diastolic volume, you get this curve. This is called as Frank-Starling law. You know this or not? That stroke volume or cardiac output is directly proportional to end diastolic volume or preload. This is your Frank-Starling law. Then one more curve is there, doctor, that if you plot curve between venous return and right atrial pressure, you will get a curve like this. What is this? Can anyone tell me? This is a wonderful question. This is your mean systemic pressure. Listen very carefully. There are two different curves and this image is amalgamation of two different images together. Okay. So, the first curve is telling you about Frank-Starling law and this is showing you contractility. What this is showing? This is showing contractility. So, if someone says that the curve is like this, if curve is like this, then what is your answer? 10 questions can be asked from this image. Okay, tell me one by one. If this image go upward, what does this mean? Contractility is more. So, it is called as positive inotropy or contractility is more. If this curve is like this, what is this? It is negative inotropy or decreased contractility. So, if you plot the curve between end diastolic volume and cardiac output, it will be like this. And if curve is upward, it means contractility is increase. If curve is downward, it means contractility is decrease. This is clear? Now, this is mean systemic pressure. If a curve is upward, it means there is increase in the mean systemic pressure. If this curve is downward, it means there is decrease in the mean systemic pressure. Now, come back to this image. This image is showing contractility. If they ask you what is this, it is increased contractility. What is this? This is decreased contractility. And what is this blue curve they are asking for? It is increased mean systemic pressure. So, answer will be what? Increased mean systemic pressure. Very simple. So, if there is upward curve in this image, it is increased mean systemic pressure. If there is upward curve in this image, it is increased contractility. Is this clear? So, this is amalgamation of two images. Now, come to this simple action potential curve. Now, this is a very simple curve. Question is asking at which labeled point on the action potential potassium is closest to the electrochemical equilibrium. At what point? At what point? At what point it is closest to the potassium nust potential? Point 1, 2, 3, 4 or 5? Yes, anyone? At what point it is closest to the potassium equilibrium potential? What should be the answer? See, this is influx of the sodium. This is outflux of the potassium. This is also outflux of the potassium. This is also outflux of the potassium. Very good. Most of you are correct. Point number 5. Very good. Excellent. Many of you are correct. Point number 5. Potassium is at resting position at point 5. It is the next potential. So, point 1 and 2 are influx of sodium. Point 4 and 5 are efflux of potassium. At point 5, efflux will be stop, and this is your next potential of the potassium. Very good. Almost everyone is correct. Very good. Now, velocity of conduction of the action potential along a nerve will be increased by. What are the factors that can increase velocity of the action potential? What are the factors that increases? What are the factors that increases velocity of action potential? Number 1, you know, if you increase the diameter of the neuron. Okay, first tell me the answer, then I will explain that. What is your answer? Velocity of conduction of action potential along nerve will be increased by. Yes, Yuvraj, Danish, Karan are saying answer D. Very good, excellent. So there are mainly two ways. Either you increase the diameter, so velocity will increase because resistance will be low, or myelinate the neuron. So answer is D. Very good. Most of you are correct. Myelination of the neuron. Myelination of the neuron. Good. Decreasing the diameter? No. Increasing the diameter of the neuron. So answer is D, not C. Very good. Now, next question. Now, this is really beautiful question because it is telling about the Fick's law of diffusion. Which of the following will double the permeability of solute in a lipid bilayer? Which of the following will double the permeability of solute in a lipid bilayer? Let me wait for 1 minute for your answer, then I will explain this. This I will tell you the hint. It depends on Fick's law of diffusion. This question is based on Fick's law of diffusion, and it says rate of diffusion is equal to change in the pressure into surface area into diffusion coefficient upon thickness. Now tell me the answer. This question is trying to confuse you, but if you know exactly the law, you will get correct. Question is not asking about rate of diffusion. Question is asking about the permeability coefficient. Question is not about the rate of diffusion. Question is about permeability coefficient. Nowadays, in every examination, in MBBS examination, in PG, they are asking these type of MCQ. Anyone? So most of you are saying D. Old monk is very only old monk is correct. Okay. Answer is B actually. Why? Why answer is B, old monk? Yes, you are correct, old monk. Your answer is B, of course. But why answer is B? It is not asking the rate of diffusion. It is asking the permeability coefficient. Diffusion coefficient or permeability coefficient is proportional to solubility of gas upon under root molecular weight. Listen very carefully. This is a beautiful question. They are not asking about rate of diffusion. If they would have asked about rate of diffusion, answer will be D. You are correct. But listen very carefully. They are asking about which of the following will double the permeability. permeability coefficient or diffusion coefficient. And what is the formula for diffusion coefficient? Solubility upon under root molecular weight. So doubling oil water partition coefficient of the solute will increase the solubility. It depends on the partition, the material of the partition. If you double the coefficient, permeability will increase, solubility will increase, and coefficient will also increase. This is different from the normal MCQ. And this is repeat MCQ. Whatever I am asking, they all has been asked in some of the examination. So this must be at your tip of the tongue. Okay, so answer is B, not the D. Okay, selective destruction of zona glomerulosa of adrenal cortex will produce a deficiency of which hormone? Zona, in the adrenal cortex, we have three layers: zona glomerulosa, zona fasciculata, and zona reticularis. So, if you destroy zona glomerulosa, which hormone will not be produced? Very simple. Yes, being simple, C. C means cortisol. What is produced by glomerulosa? Glomerulosa produces which hormone? Aldosterone. Fasciculata produces which hormone? Cortisol. And reticularis produce dihydroepiandrosterone. So it will convert into testosterone and then into estrogen. I have given you mnemonic in the class. It is the salt hormone. This is the sugar hormone. And this is the sex hormone. The more you go deeper, the more it becomes sweeter. Salt, sugar and sex. So outermost layer is salt, aldosterone. So if you destroy the zona glomerulosa, aldosterone will not be produced, yes or no? So answer will be A. Yes. Answer will be, of course, A. Very good, most of you are correct now. So if you destroy zona glomerulosa, aldosterone will not be produced. If you destroy fasciculata, cortisol will not be produced. If you destroy reticularis, dihydroepiandrosterone, testosterone and estrogen will not be produced. Am I clear? Very simple question. Salt hormone, sugar hormone and sex hormone. One more question I want to ask you, which is the only layer that does not, which is not controlled by ACTH? Which is the only layer that is not controlled by ACTH? And answer is zona glomerulosa. Fasciculata and reticularis is controlled by what? They are controlled by ACTH. But glomerulosa is controlled by hyperkalemia. Hyperkalemia will release more aldosterone because it will cause secretion of the potassium and potassium become normal. So, which is the most potent stimulant of aldosterone? Answer is hyperkalemia. Next question. Which of the following explain suppression of lactation during pregnancy? Why lactation is suppressed if someone becomes pregnant? What is the answer? What is the answer? Why lactation is suppressed if someone becomes pregnant? What is the reason? Blood prolactin level are too low for the milk production. Human placental lactogen level are too low. Fetal adrenal gland does not produce sufficient estradiol, or blood level of estrogen and progesterone are high. See, only by solving MCQ your concept can be clear. It is not that in exam MCQ are coming. Only if you solve MCQ, then only you can have good concept. Harshita Mali is absolutely correct. Very good, excellent. See, this is a very paradoxical thing. Estrogen increase prolactin. Estrogen increase prolactin, but In the pregnancy, you have estrogen and progesterone both. So when they are present in combination, this decrease prolactin. That is why during pregnancy or someone become pregnant, prolactin is suppressed. Okay, next question. A 46-year-old woman has hirsutism, hyperglycemia, obesity, muscle wasting, increased level of ACTH. Most likely cause of symptom is, if some girl is having or women is having hirsutism, facial hair, hyperglycemia, centripetal obesity, muscle wasting, increased level of ACTH, what is your diagnosis? See, this is a very important question. What is the diagnosis? First tell me the diagnosis. Visesh Sen is saying C. Okay, excellent. Answer is Cushing disease. Very good. Cushing disease have excessive cortisol. Excessive cortisol. And cortisol is hyperglycemic hormone. It is hyperglycemic hormone. But here cause is in the adrenal cortex or cause lies in the pituitary gland. What is the answer? Cushing disease can be of two types. Cause can be in adrenal cortex or cause can be from pituitary gland. Cause is the pituitary gland. Pituitary gland may be, there can be some adenoma which is increasing ACTH and that causes increased cortisol which produces hirsutism, hyperglycemia, obesity. Which type of obesity is this? Centripetal obesity. Buffalo hump is there. Why? Because cortisol is a lipolytic hormone. Now you will ask me that cortisol is a lipolytic hormone, so why patient is obese? My question is that if cortisol is a lipolytic hormone, why there is obesity? If cortisol is lysing the fat, why there is obesity? Reason is that it mobilizes fat from the periphery to the center. So central body will be obese, but periphery will be lean and thin. Skin will be very, very thin. They will have purple stria also. Okay, and obesity will be central. It is called as centripetal obesity. They have buffalo hump on the back. They have a hump because of collection of fat. Okay. Yes, lemon on stick. Very good. Which of the following decreases conversion of 25 hydroxycholecalciferol to 125 dihydroxycholecalciferol? What is the answer? I hope you remember this diagram. Skin has, what is the answer? Tell me. 7D hydro cholesterol. When ultraviolet rays fall, it is converted into cholecalciferol. In the liver, it forms into 25 hydroxycholecalciferol, and in the kidney, in presence of parathormone and 1 alpha hydroxylase, it convert into 125 dihydroxycholecalciferol. So what is the answer? Someone are saying C, someone saying D. What is the answer? Where 125 dihydroxycholecalciferol is formed? Where it is formed? The conversion of 25 hydroxycholecalciferol into 125 dihydroxycholecalciferol happen where in your body? In the kidney, na? In the kidney. So if there is kidney failure, if there is chronic renal failure, this conversion will not happen at all. That is why in kidney disease, we use supplement of vitamin D3, or in hypoparathyroidism, not hyper, because parathormone is also needed. Parathormone is needed to conversion of 25 hydroxycholecalciferol into 125 dihydroxycholecalciferol. So this hormone can be decreased in two conditions. One can be kidney disease, other can be hypoparathyroidism. Okay. Now tell me, which is the supplement form? When you give supplement of vitamin D3, you give A or you give B? A or B? When you give supplement of vitamin D3 normally, you give 25 hydroxycholecalciferol or 125 hydroxycholecalciferol. Which is the supplement form? Yes, which is the supplement form? Which is the supplement form? Yes, very good. Which is A. Because A is converted into B in the kidney. A can be converted, 25 hydroxycholecalciferol can be converted into 125 dihydroxycholecalciferol in the kidney. So we give A. But in the kidney disease and in the hypoparathyroidism, we always give the active form. Which is the active form? 125 dihydroxycholecalciferol. 125 dihydroxycholecalciferol. Is this clear? Okay. Next question. Which of the following is characteristic of saliva? Which of the following is characteristic of saliva? It is hypotonic to the plasma. Yes or no? Bicarbonate is less than plasma. Presence of protease or secretion rate is increased by vagotomy. Which is correct regarding salivary secretion? Which is correct regarding salivary secretion? Is it hypotonic related to the plasma? Yes or no? A, D. Please everyone try to answer. Don't hesitate in answering. You can be right, you can be wrong. If you are wrong, you will learn. No problem. Secretion rate is increased by vagotomy. Vagus is parasympathetic. So when you are relaxed, you have more saliva. And when you are in tension, your mouth is dry. When you are going for your first, your mouth is dry, you want to drink water. So why? Because when you are in tension, mouth is dry. So vagus is parasympathetic. It increases secretion. So if you do vagotomy, secretion rate become more or less? It become less. It become less. Yes or no? Presence of protease. Saliva can digest carbohydrate, it can digest fat, but not protease. It is absence of protease. Yes or no? Saliva can digest carbohydrate, can digest fat, but not protein. Absence of protease, not presence of. Bicarbonate is more or less. We have discussed this. Bicarbonate is more. There is a lot of bicarbonate in the saliva. It is acting like an antacid. When you wake up in the morning, this saliva help like antacid. That is why we should drink water when you wake up in the morning, even before brushing your teeth. Saliva has lot of bicarbonate, lot of antibodies. Hypotonic to the plasma? Yes, of course. Saliva has lot of bicarbonate. Saliva has lot of proton. Lot of proton and lot of bicarbonate. Never forget this. And vagus is the parasympathetic nerve. More is the vagus secretion, more will be the saliva. If you cut, secretion will be decreased. Okay. Which of the following substance is secreted in response to oral glucose load? If you take 75 gram of glucose or 100 whatever, if you take glucose, which hormone will increase? I will tell you a hint. That is called as incretin hormone. That is called as incretin hormone. Tell me fast, there are 90 questions. We cannot give more time then. If you take glucose, which hormone will increase? Yes, tell me the answer. What is the answer? Which hormone is incretin hormone? There are two hormones that are incretin. Yes, very good. Answer is D. There are two incretin hormone. One is glucose dependent insulinotropic peptide GIP and second is GLP. This is by L cell, this is by K cell. If I give oral glucose and if I give IV glucose, in which condition insulin is more? Yes, answer is D. Very good. Most of you are correct. Wonderful. In which condition? Yes, when you give oral glucose, insulin secretion is more. Why? When you take oral glucose, it will pass through the intestine and K cell and L cell will release incretin hormone, that is GLP and GIP, and these will stimulate beta cell to release insulin. This is called as incretin phenomena, and that is why in diabetes we give GLP-1 agonist drug like exenatide, liraglutide, dulaglutide. All these are subcutaneous injection that can be given in diabetes patient that increases the release of insulin. Okay, only one drug is available as oral drug, GLP-1 agonist, and that is semaglutide. It is a recent question. Now this GLP-1 is degraded by which enzyme? DPP-4. That is why if we give DPP-4 inhibitor like gliptins, sitagliptin, linagliptin, vildagliptin, sexagliptin, all gliptins inhibit the degradation of GLP-1, increases GLP-1, increases the release of insulin. So these are called as incretin hormone. Which of the following is true about secretion of exocrine pancreas? Which of the following is true about exocrine pancreas? Yes, tell me. Which of the following is true regarding exocrine? It has higher chloride, it is stimulated by presence of bicarbonate, pancreatic bicarbonate is increased by gastrin, or it is increased by cholecystokinin. Very simple question. Name is suggesting the answer. See, these are very simple concepts. You need to revise your notes and do as much as MCQ as possible. Only by doing MCQ you can remember the fact. What is the answer? Piyush, D. Deepika Yadav, D. Okay. Harshita, D. Visesh, D. So most of you are saying D. Excellent. It has higher chloride or bicarbonate. Bicarbonate. Okay. It is secreted, is increased by cholecystokinin pancreozymin. Name is suggesting, okay, it is increasing by and pancreatic secretion. It causes contraction of gallbladder and increased pancreatic secretion. And pancreatic bicarbonate secretion is increased by gastrin? No, by secretin. By secretin. Keep on revising your notes. So answer is D, because all three are incorrect. They have more of bicarbonate, not chloride. Chloride is wrong. They are stimulated by presence of bicarbonate? No. Pancreatic bicarbonate is increased by gastrin? No, by secretin. So answer is D, that pancreatic enzyme secretion is increased by cholecystokinin. Now, which of the following substance must be further digested before it can be absorbed by a specific carrier in the intestine? Which need to be further digested? Fructose, sucrose, alanine or dipeptide? Sucrose, fructose, alanine or dipeptide? These are example of glucose, and this is of amino acid. Now, which need to be broken before absorption? Very simple question. Glucose or amino acids? Can glucose be absorbed in monomer, dimer and trimer, polypeptide and polymer? Can it be absorbed or only in monomer? Very good. A lot of answers are coming. Fructose, glucose and galactose. These are the monomer. Carbohydrate can be absorbed only as monomer, not as dimer. Sucrose cannot be absorbed. It has to be broken down. Remember very carefully, carbohydrate need to be broken down into monomer, only then it can be absorbed. On the other hand, peptides can be absorbed as a tripeptide, no problem. Amino acids can be absorbed, proteins can be absorbed, like a dipeptide, tripeptide. They have peptide transporter, pepti. But carbohydrate can only be absorbed in the form of monomer. And what is monomer? Glucose, galactose and fructose. These are the monomer. Next question. Slow wave in small intestinal smooth muscles are. What are the slow waves? If you remember the diagram, these are your slow waves or basic electric rhythm. This is your threshold. This is your slow wave. These are slow waves, also called as basic electric rhythm, and these are generated by, who are the pacemaker of slow wave? Interstitial cell of Kajal or Kahal or Kajal, whatever you can say. These slow waves are generated by interstitial cell of Kahal, or you can say Kajal, whatever you can say, but correct pronunciation is Kahal. Okay. So, what are the slow waves? D, C, D. They are action potential, they are phasic contraction, they are tonic contraction, or they are oscillating resting membrane potential. Most of you are correct. They are oscillating resting membrane potential. This is the beautiful slow waves. Slow waves are nothing, they are simply what? Restless potential. Restless, oscillating, fluctuating. So, fluctuating resting membrane potential are called as slow waves. So, this is different from the skeletal muscle and the cardiac muscle. Here RMP is fluctuating, and the fluctuating RMP is called as slow waves or basic electric rhythm. Remember, these slow waves are RMP, they cannot produce peristalsis. Only when you eat something and calcium come inside and they start fluctuating. When they touch the threshold, there are spike potential. And only when there is a spike potential, only these can cause peristalsis. I hope you remember this diagram. So, spike potentials are action potentials which can generate peristalsis, not slow waves. Slow waves cannot generate peristalsis because slow waves are what? Slow waves are not phasic contraction, they are not action potential, they are not tonic contraction, they are oscillating resting membrane potential. They are fluctuating resting membrane potential generated by interstitial cell of Kahal or Kajal, whatever you say. So, this is called as slow waves. They are maximum in the duodenum and minimum in the cecum. Slow waves are maximum in the duodenum, minimum in the cecum. Next question. Which adrenergic receptor produce its stimulatory effect by formation of IP3 and calcium? Which receptor is this? Is it GS, is it GI or is it GQ? Very, very important question. One or two questions are definitely coming in every exam regarding this topic. IP3 and DAG, calcium is the secondary messenger of what? GS, GI or GQ. G protein couple receptor I am talking about. They are GS or they are GI or they are GQ. We says they are GQ. GS and GI have cyclic AMP as a secondary messenger. They are asking which receptor is GQ. Please remember, all beta receptor are GS. All beta receptor are G stimulatory. G stimulatory. Alpha 1 is GQ. Alpha 2 is GI. Muscarinic 1, muscarinic 3, muscarinic 5 is GQ. Muscarinic 2, muscarinic 4 is GI. Please remember this much. All beta receptor are G stimulatory. All beta are G stimulatory. Alpha 2 is GI, alpha 1 is GQ. So answer is what? Yes, Piyush is correct. Answer is A. Vishesh is also. Many of you are correct. Answer is A. Alpha 1 adrenergic receptor. Next question. Excessive muscle tone produced in decerebrate rigidity can be reversed by. Beautiful question. You know, there is decorticate rigidity. There are two. There is decorticate rigidity and there is decerebrate rigidity. What is the difference between these two? There is decorticate rigidity and decerebrate rigidity. In decorticate rigidity, cortex is removed. If you remember, I hope you are revising the notes. In decerebrate rigidity, you are removing the cortex and midbrain. Okay, in both you are removing the cortex, so there is rigidity. In here, midbrain is also removed, so rubrospinal tract is also damaged. If you remember, let me revise that. In decorticate rigidity, patient is like this. Hand are on the chest. Body is rigid, hand are on the chest. In decerebrate rigidity, hands are lying on the side of the body. Now, question is that this rigidity is because of what? Gamma motor neuron discharge. So, how can you abolish? Simply abolish the afferent, and afferent is going by which route? Dorsal route. All afferent 1A, 2, 1B, all are going via dorsal route. In the spinal cord, any sensory information is going via dorsal route. Dorsal route are sensory. This is called as Bell-Mendendy law. If you cut the dorsal route, no afferent will go, no efferent will come. So, gamma motor discharge will stop. You can reverse the rigidity. Okay. So, this is a very important clinical question, that excessive rigidity can be reversed by cutting the dorsal route. Which of the following body part has maximum representation on primary motor cortex? Which has maximum representation? Which part of your body? Which is most active part of your body? That will have more is the function, more will be the representation in your brain. More is the function, more is the representation in your brain. Which part is having maximum function? Which part is having maximum function? If they have maximum function, they have maximum representation. Yes, shoulder is not shoulder, ankle, elbow. Fingers, you are writing with the finger, you are swiping with the finger, whatever you are doing, you are using your thumb, especially the thumb. So, answer is finger. Very good. Cutting which structure on the right side cause blindness in the temporal field of the left eye and the nasal field of the right eye? This is your eye. This is your temporal field of the left eye. Suppose this is the left eye, and nasal field of the right eye. There are two types of hemianopia. You know, one is, remember this mnemonic, one is bitemporal hemianopia, other is this homonymous hemianopia. This is because of lesion to the optic tract, and this is because of lesion to the optic chiasma. In bitemporal hemianopia, temporal side is only damaged. So if they are asking about bitemporal, answer will be optic chiasma. But they are asking about this, so option is optic tract. Please remember, bitemporal hemianopia, answer will be optic chiasma. BTH ka chasma. I used to remember like that, BTH chasma. BTH is the brand of, specs. So bitemporal hemianopia, if it is bitemporal hemianopia, temporal side is involved, answer is optic chiasma. If this is involved like this, optic tract. So answer is optic tract. Good, most of you are correct. A ballet dancer spin to the left. During the spin, her eyes snap quickly to the left. This movement is called as. If you are sitting in a train or a moving object, or you are rotating like that, your eyes will do tuck, 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 tuck. What is this called as? If you are spinning like that, like a ballet dancer, or you are sitting in a moving object like a train, you are looking outward and you are catching one tree, then second tree, and the third tree. This is called as simply nystagmus. It is physiological nystagmus. The jerky movement of the eye is called as nystagmus, isn't it? In which condition you get pathological nystagmus? If there is lesion of MLF, what is MLF? You must be familiar with MLF. Some people are fan of this tract. Medial longitudinal fasciculus. It will cause pathological nystagmus. Post-rotatory is, see, the fast eye movement that occur during the spin is called as nystagmus, and it occurs in the same direction as the rotation. But after the spin, post-rotatory nystagmus occur in the opposite direction. If you are spinning, your eyes will spin in the same direction. This is called as rotatory nystagmus. But even after you stop, for some time, you keep on having post-rotatory nystagmus on the opposite direction. This is happening in the same direction. Spin to the left, and eye is also going to the left. So both are going in the same direction. So it is nystagmus. If you stop the rotation, even after the rotation is stopped, the ballet dancer will have post-rotatory nystagmus on the opposite side. This is called as post-rotatory nystagmus. Ataxia you will get in cerebellar lesion. Aphasia you can get Broca's aphasia, Wernicke's aphasia. There are so many aphasia. Am I clear? Okay. Which of the following would produce increase in resorption of isoosmotic fluid in the proximal tubule? What can cause increase in the absorption of proximal fluid? What can cause increase absorption of water from proximal fluid? Let me tell you one thing is TGF and one thing is GTF. It is not KGF. You remember KGF, you forget TGF and GTF. This will make you doctor. KGF will not make you doctor. So TGF is, it maintains the GFR, and this is about GTF. So what is the answer? This question is regarding glomerulotubular feedback mechanism. Glomerulofeedback tubular mechanism. Yes, Sane, A or D? Let me tell you. Suppose these are your afferent arteriole and the efferent arteriole. Afferent arteriole and the efferent arteriole. Suppose there is more amount of filtration. If there is more amount of filtration due to any cause, Proteins are not filtered, so proteins will be accumulated and this protein will reabsorb. You know there are two pressure. Hydrostatic pressure is moving the water, oncotic pressure is retaining the water, So if there is more filtration fraction, more plasma is filtered. Remember that proteins are not filtered. So more proteins will be accumulated, more will be the oncotic pressure and more will be the resorption of water. This is a wonderful method. If water absorption is more will be the reabsorption. This is called as GTF, glomerulotubular feedback mechanism. So due to any cause, if there is more of filtration fraction, more and more plasma is filtered, more and more proteins are accumulated. More proteins means more oncotic pressure, more will be the water resorption. Isn't it the beautiful mechanism? How even more water is filtered, more will be the absorption. Automatically, this is an automatic method. If you are wasting more water in the plasma filtration, it will be automatically absorbed. Why? Because of increased oncotic pressure. This is called as glomerulotubular feedback mechanism. Which of the following substance can be used to measure interstitial fluid volume? Which of the following substance or combination of substance could be used to measure interstitial fluid volume? What is the answer? We says D. Inulin. If you remember in my classes, I used to tell you that I and IRI, intracellular fluid and interstitial fluid, are measured indirectly. What is ISF? Interstitial fluid don't have any dye. It is equal to ECF minus plasma. ECF is measured by inulin. Plasma is measured by radioactive albumin. So at least you will need two marker or these substances to measure interstitial fluid. I and IRI, intracellular fluid, can be measured by total body water minus ECF. You will use mannitol and you will use inulin. So these are the two I which are measured indirectly. You will need two in inulin and radioactive albumin. At plasma, para-aminohippuric acid concentration below the transport maximum, PAH reabsorption is not saturated, clearance equal to inulin clearance, secretion rate equal to the PAH secretion, or concentration in the renal vein is close to 0. If you remember about PAH, which I have discussed in so many classes, it is fully filtered and fully secreted if it is below transport maximum. What is the answer? Let me see the answer, then I will explain it. Yes. If it is below transport maximum, no problem. If it is below Tmax, problem arises when it is above Tmax. It cannot be secreted fully. It will go in the vein. Harshita Mali T, Yashvardhan B, Akshita D. Please try to answer. See, whatever you are doing, if it is fully filtered and fully secreted, 100% will come in the clearance. Nothing will go in the renal vein. Nothing will go in the renal vein because you are giving below T max. But if you give above T max, okay, only something will be secreted, rest amount will go in the renal vein. So here you are giving below the T max. Here you are giving below transport maximum. So concentration in the renal vein will be close to 0, because the amount you are using is appropriate. It is below transport maximum. So nothing will go in the renal vein. All will be secreted in the urine, excreted in the urine, cleared in the urine. But if you are using the concentration of para amino hippuric acid more than transport maximum, some amount will start getting in the renal vein. Am I clear till now? Okay. This is a wonderful question. Nowadays 7 to 8 questions are asked only on the pH. So be perfect in this. pH is 7.52. How much is the pH? pH is 7.52. PCO2 is 20. Bicarbonate is 16. Which of the following statement is correct? First tell me the diagnosis. Is it metabolic alkalosis or acidosis or respiratory? What is your diagnosis? First tell me that, then I will tell you. 7.52. It is acidosis or alkalosis? Is this acidosis or it is alkalosis? Tell me. Is it alkalosis? It is alkalosis. Which one? Respiratory or metabolic? Harshita Mali, you are correct. Because of washout of, see, carbon dioxide is 40. Carbon dioxide is 40, but here it is only 20. It means there is washout of the carbon dioxide. So it is respiratory alkalosis with compensatory metabolic acidosis. So patient is hyperventilating or hypoventilating. If this is respiratory alkalosis, patient is hyperventilating or hypoventilating. Tell me. Carbon dioxide washout is there. So it is not hypo, it should be hyperventilating. Yes, Harshita is correct. Answer is B. Very good. Why answer is B? Whenever there is alkalosis, see, this is the protein. Proteins are most abundant buffer. If there is alkalosis, proton will be less and the rest of the site will be bound by calcium. So free calcium will become less and this will cause tetany. This will cause tetany. Okay. So answer is decrease ionic calcium. Am I clear or not? Remember, tetany can be caused by hypocalcemia, hypomagnesemia and metabolic alkalosis. Okay. So patient is hyperventilating na. So carbon dioxide washout is there. So the diagnosis is respiratory alkalosis with compensatory metabolic acidosis. And remember, whenever there is alkalosis, H ion will be less. So all H ion will bound with the protein, calcium. H ion will be less. So H ion will be less. So more will be the free calcium will bind with the protein. So availability of free calcium will be less and it can cause tetany. This question has been done. Okay, now second test series. Okay. What process is responsible for change in the membrane potential that occur between point 1 to point 3? Point 1 to point 3, what is this? You know that. Influx of sodium, outflux of sodium, influx of potassium or outflux of potassium. You know this is depolarization. So what will be the answer? From point 1 to point 3. What is the answer? Influx of what? Sodium or potassium? Sodium. Influx of sodium. And this is outflux of potassium. Okay, simple question. Next question. A 30-year-old female patient ECG showed 2p wave preceding each QRS. First tell me the diagnosis, then I will tell you the answer. 2p wave followed by 1 QRS. 1p, 2p, QRST, 1p, 2p, QRST, 1p, 2p, QRST. What is the correct diagnosis? Which type of, heart block it is? If there are 2p followed by 1 QRS, which type of heart block it is? Yes, very good, Sai. Very good, Sai. Answer is 2:1 heart block. It is Mobis 1 or Mobis 2? It is Mobis 1 or Mobis 2? It is first degree, second degree or third degree? First tell me this one. It is first degree heart block or second degree heart block or third degree heart block? First degree heart block, second degree or third degree? Of course, it is second degree. In second degree, if you remember, we have discussed Mobis 1 and Mobis 2. In Mobis 1, you get Wenke-Beck phenomena. In Mobis 2, you get 2:1. So, this is example of Mobis 2. This is example of Mobis 1. If you remember, in first degree heart block, there is only increase in PR interval. Just open your notes and see. In the first degree heart block, there is increase in PR interval. In second degree heart block, one P wave will miss QRS. It can be Mobis 1, it can be Mobis 2. In Mobis 1, there is a Wenke-Beck phenomena. In Mobis 2, it can be 2:1 or 3:1. So, in all type of heart block, there is decreased conduction through AV node. Whatever be the heart block. It means what? Heart block means what? AV nodal delay is increased. So, answer will be D. Clear? Okay, next question. Acute decrease in the blood pressure will cause which compensatory change? If there is decrease in the BP, what will happen to what? There will be decreased firing of carotid sinus, increased parasympathetic outflow, decreased heart rate or decreased contractility. Do you remember every step I have told you when there is decrease in the BP? A, D, okay. This is regulation of BP, everyone should answer. If BP is low, I hope you remember, if BP is low, stretch will be low, firing will be low. It will stimulate sympathetic system. It will inhibit parasympathetic system. Heart rate will increase, contractility will increase, and vasoconstriction will be there to increase the BP. So, answer is A, of course, very good. Most of you are correct. Decrease firing rate. Now, most people think if BP is low, firing is high. No. If BP is low, stretch is low, firing is low. And this will activate your sympathetic system. So, parasympathetic is inhibited. Heart rate is increased, contractility is increased. So, the only correct answer will be A. Decrease BP means decrease firing rate. If increase BP, increase firing, Okay, inhibition of sympathetic and activation of parasympathetic. Tendency for edema to occur will be increased by tendency of edema. This is the capillary, this is interstitium. There is more fluid in the interstitium, this is called as edema. So what can increase the tendency of edema? What can increase the tendency for edema? See, hydrostatic pressure of the capillary increase fluid edema, I mean. Oncotic pressure of the capillary reduce edema. Hydrostatic pressure of the interstitium reduce edema, and oncotic pressure of interstitium increase chance of edema. Visesh C, Roy C, Deepika Gupta B. Okay. If you are saying C, C means increase plasma protein. If plasma protein is more, oncotic pressure will be more, retention of water will be more, so edema will be less. That is why in liver disease and kidney disease, plasma protein are less, so retention is less, so edema is more. So this is not the answer. It should be less plasma protein. If muscle activity is more, edema will be less. Arterial constriction, no. Increase venous pressure will increase hydrostatic pressure of the capillary. More blood is going, more will be the hydrostatic pressure, more will be the filtration, and more will be the edema. More will be the edema. That is why in liver disease and kidney disease, when in the liver disease protein will not be formed. In kidney disease there is albuminuria. So in those both condition, when plasma protein is less, oncotic pressure is less, retention is less, so edema is more. Am I clear? Inspiration split the second heart sound. You know we have lub dub, but lub drop. Dub is like drop. It is a split. You get S1 and S2 is like this. It is not sync. First one sound will come, then other sound. So they are asking which sound will come first. In S1, S1 is due to closure of AV valve and S2 is due to closure of aortic and pulmonary valve. But aortic and pulmonary come separate, especially during inspiration. So they are asking why during inspiration, which valve will close first. What is the answer? Yes, please everyone try to answer. Don't hesitate in being wrong. If you are wrong, you will be corrected. But if you don't answer, you will forget. Only if you answer and if you are correct, it is good. If you are wrong, you will learn. What is the answer? Which valve close first, aortic or pulmonary? Very simple question. Firefly, aortic closes before pulmonary. What about others? Yes, aortic will come first, pulmonary will come later on. Very good. So A2, P2, lub, drop. It is drop, it is not dub. It is drop. It will take some time. So when you hear the sound, lub is very, pinpoint, but drop is because A2 come first, P2 come. So answer will be aortic valve closes before pulmonary valve. During exercise, total peripheral resistance decreases because of effect of. During exercise, okay, tell me one thing. When you exercise mild, not mild, but moderate to severe, when you exercise moderate to severe, okay, systolic BP and diastolic BP, what will happen and why? If you are doing exercise, systolic BP will increase or decrease? It will increase. And diastolic BP, it will decrease. Why so? This is your heart, this is your aortic valve, this is your arteries, and these are your arterioles. This is your muscle. When you are doing exercise, when aortic valve is open, this is systolic BP. You are getting blood directly from the heart. You are getting blood directly from the heart. But during diastole, aortic valves are closed. So from where muscle is getting blood? By arteriodilation. So total peripheral resistance and diastolic BP both will decrease. Why? Because of local metabolites on skeletal muscle arteriole. When you are doing exercise, okay, adenosine, potassium, these will increase and these will cause vasodilation, arteriolodilation. Blood will sweep from the aorta to the muscle, so the total peripheral resistance will be less, diastolic BP will be less, because arterial dilation depends on what? Local metabolites. When you exercise, lactic acid, adenosine all will increase, and this causes arteriolodilation. Now, curve A in the figure represent what? What is represented by curve A and what is represented by curve B? What is represented by curve A? See, it is coming after QRS. Which pressure is increasing after QRS? Which pressure is increasing after QRS? Okay, let me give you option. Aortic pressure, ventricular pressure, atrial pressure, or ventricular volume. What is curve A and what is curve B? QRS means what? Ventricular contraction. So after ventricle will contract, what will increase? Which pressure will increase? Aortic pressure or ventricular pressure or atrial or ventricular volume? When blood get from ventricle to the aorta, whose pressure will increase? When all blood went from ventricle to the aorta, ventricle is empty now. So whose pressure will increase? After QRS, whose pressure is increased? This is dicrotic notch also. This is called as dicrotic notch. Tell me. Yes, Sai, you are correct. Aortic pressure. After QRS, after ventricular contraction, all blood will go to the aorta. So this is aortic pressure. What is this? This is aortic pressure. Aortic pressure will increase, and what will decrease accordingly? As aortic pressure increase, volume of ventricle will decrease. So this is aortic pressure and this is ventricular volume. Am I clear or not? Is this point clear? So as QRS happen, ventricular depolarization happen, ventricle will contract, pressure of aorta will increase and volume of ventricle will decrease. So A is your aortic pressure and B is the ventricular volume, and this is your aortic notch by closure of aortic valve. When aortic valve close, there is a notch called as aortic dicrotic notch. Okay, these two questions. A newly developed drug, local anesthesia, it blocks sodium channel in the nerve. Which of the following effect on action potential would be expected to produce if you give a drug that blocks sodium channel? A very simple question. If a drug is blocking sodium channel, what will be affected? Very simple. If a drug is blocking sodium channel, what is affected? Decrease the rate of rise of upstroke of action potential, means depolarization, shorten refractory period, abolish hyperpolarization. This is your action potential and you are blocking sodium channel. It cannot be simpler than that. If you block sodium channel is causing what? Yes, depolarization, upstroke. So sodium is causing upstroke. So there will be a decrease in the rate of upstroke. Simple question. Very simple. If you are giving sodium blocker, it will block upstroke or depolarization. It will decrease the rate of rise of upstroke. Simply. And IPSP, inhibitory post-synaptic potential. Do you remember there are two things, IPSP and EPSP? Both are local potential. Inhibitory post-synaptic potential is causing hyperpolarization. Excitatory post-synaptic potential causes depolarization. Now tell me, what can cause hyperpolarization and what can cause depolarization? And IPSP, depolarization is due to influx of cation. Hyperpolarization is due to influx of anion. Very simple. What is the answer? Hyperpolarization is due to influx of anion, negative charge. EPSP is due to influx of cation. And question is about IPSP. This is your, in MBBS first year, this question is asked as a short note, IPSP and EPSP. IPSP and EPSP both are local potential. Inhibitory post-synaptic potential is causing hyperpolarization. Yes, what is the answer? Okay, very good. Answer is D. Hyperpolarizes the post-synaptic potential by opening chloride channel. So answer is D. EPSP causes depolarization. IPSP causes hyperpolarization. Okay. Which of the following can occur as a result of inhibition of sodium potassium pump? Which of the following? This is about a drug. Can you name a drug that blocks sodium potassium pump? Can you name a drug that blocks sodium potassium pump? Can you name it? Digitalis. If you block sodium potassium pump is causing what? Outflux of 3 sodium, influx of 2 potassium. It will decrease intracellular sodium. Yes, it will decrease or increase. If you block this pump, sodium will be less inside or less outside. Pump is pulling sodium out. So if you block the sodium will be increased intracellularly. It will be increased intracellularly. Increase intracellular potassium? No. It will decrease intracellularly. Increase intracellular calcium? Yes. How? This is your heart. Your heart is having sodium potassium pump. 3 sodium, 2 potassium. Your heart also have sodium calcium importer, antiporter. Your heart have 2 pump, sodium potassium pump and sodium calcium antiporter. Now if you block this channel, calcium will not go outside, calcium will be more inside the cell and this will cause increased contraction. That is why digitalis, this is how digitalis is causing positive inotropy. So answer will be C, increase intracellular calcium concentration. You must know that digitalis block sodium potassium pump and accumulate more of the calcium, so more of the contraction causing inotropy. Okay. Next question. What is the sequence of excitation, contraction, coupling in the muscle? What is the sequence of excitation, contraction, coupling of the skeletal muscle? First, what will come, then what will happen, then what will happen, and then what is release? What is the correct sequence of excitation, contraction, coupling? Yes, B. Okay. Any other answer? Any other answer? Action potential will go inside the first step. Depolarization of the T tubule, second step. Release of calcium is the third step. So answer is of course B. This is called as excitation, contraction, coupling. And which receptor is this? This is called as dihydropyridine receptor, and this is called as ryanodine receptor. Now go very fast. This we have done. Okay. Same question with a different sequence. In the skeletal muscle, which of the following event occur before depolarization of the T tubule? Before depolarization of the T tubule, what will happen? Before depolarization of the T tubule, what is going to happen? Very simple question. Be fast, I have to finish by 10:30. They are very important question. Before T tubule, sarcolemma membrane will be depolarized, na? First it will go to the membrane and then to the T tubule. It's very easy. First membrane will be depolarized and then T tubule. So answer is A. Blood level of which of the following is decreased in the grave disease? Blood level of which of the following will be decreased in the grave disease? Grave disease is what? Hyperthyroidism. In hyperthyroid, what is less? What is less in hyperthyroid, my dear? T3 will be more, T4 will be more. What is less? What will be less? Yes, TSH will be less. If TSH is less, it is hyperthyroid. If TSH is more, it is hypothyroid. Very simple. So answer is D. Which of the following hormone act by IP3 and calcium? It is asking for which receptor? GS, GI or GQ? Which hormone act by IP3 and calcium? I told you it is GQ. Yes, what is the answer? Am I audible and visible? think my network is not working. Yes, what is the answer of GQ? I have told you all releasing hormone are example of GQ receptor. All releasing hormone. So releasing hormone is which one? GnRH, gonadotropin releasing hormone. Rest all are, this is acting on the nucleus, and this is your G stimulatory. Let me check. I don't know why I cannot see the comment. Let me see. Why comments are not visible to me? My network, I think, is. Just give me 1 second. Okay. So all releasing hormone are GQ. So answer is GnRH. Okay. Next question. The source of estrogen during second and third trimester of pregnancy is. What is the source of estrogen during second and third trimester of pregnancy? The source of estrogen during second and third trimester of pregnancy is corpus luteum, maternal ovaries, fetal ovaries, or fetal adrenal gland or liver and placenta. From where estrogen is produced in the second and third? Don't think that mother is giving everything to the fetus. Fetus is also giving something to the mother. The source of estrogen in the second and the third trimester is fetal adrenal gland, fetal liver and placenta. We used to study it comes from placenta. But from where? It comes from heaven. From where? Fetal liver, fetal adrenal gland. Of course, it comes from placenta. It crosses the placenta, but from the fetus. So fetus is also helping mother in providing the estrogen. So the source of estrogen in the second and third trimester is fetal adrenal gland. Okay. Which of the following cause increase aldosterone secretion? Which of the following cause increase aldosterone secretion? I have told you, what are the stimulus of aldosterone? It is not ACTH. The first stimulus is hyperkalemia. The second stimulus is decreased blood volume. And the third stimulus is decreased sodium. So here, what is the main stimulus for increase aldosterone? What is the answer? We say saying it is hypokalemia, my dear. It is the hyperkalemia. All students mark always the kalemia. Hyperkalemia, when potassium is more, it will be secreted by the aldosterone. Hypokalemia, aldosterone will be less, not more. So answer is decreased blood volume. Answer is A. Next question, secretion of oxytocin is increased by. Secretion of oxytocin is increased by milk ejection, dilation of cervix, increased prolactin, or increased ECF. Secretion of oxytocin is increased by. Even I would mark hypokalemia. Potassium is, we know potassium is aldosterone. We forget about hyper. So even if I see for the first time, I will also, but hyperkalemia. We have to remember it is hyperkalemia, hypovolemia and hyponatremia. What is the answer? Some are saying A, Nagathan and Deepika is saying B. What about others? Oxytocin is released because of what? Any other answer? Please try to answer. Don't hesitate in answering. I don't know why. C. Milk ejection is caused by oxytocin. Question is not asking that oxytocin cause milk ejection. No. Secretion of oxytocin is increased by. Listen very carefully. Very important point. Secretion of oxytocin. Question is not asking that oxytocin causes. Then answer will be milk ejection. Oxytocin release is by, answer is dilation of the cervix and nipple stimulation, suckling by the baby. Baby means newborn. Okay, so nipple stimulation and dilation of cervix will cause secretion of oxytocin, and oxytocin will cause milk ejection. Oxytocin will cause what? Okay, is this clear? So there are two main cause, suckling and dilation of the cervix. Yes, you are correct, Nagathan. Suckling and dilation of the cervix are the physiological stimuli for oxytocin. Milk ejection is a result of oxytocin, not the stimulus of oxytocin. A 61-year-old woman with hyperthyroid is treated with propylthiouracil. This will reduce synthesis of thyroid hormone because it inhibits oxidation of what? Propylthiouracil, methimazole and carbimazole all are working on one enzyme. What is that enzyme? Propylthiouracil, methimazole and carbimazole. They all work on one enzyme. What is that? Thyroid peroxidase enzyme. And the TPO have three functions. One is it cause oxidation of iodide into iodine. It cause what? What was that? Organification. It cause coupling reaction. So if you inhibit TPO, you inhibit these three reactions. So you inhibit oxidation of what? Whose oxidation is inhibited by if you inhibit TPO? What is the answer now? Even now, what is the answer now? Oxidation of what? Iodide into iodine. So answer is D. Is this clear or not? See, all anti-thyroid drug, methimazole, carbimazole, propylthiouracil, they inhibit thyroid peroxidase enzyme, TPO. And TPO is causing three things: oxidation, organification and coupling. Oxidation of iodide into iodine. So answer will be D. Iodide is converted into iodine by TPO. Okay, so answer is D. Which of the following substance inhibit gastric emptying? Which of the following substance inhibit gastric emptying? Fast. Tell me the answer. You know this answer. Very famous question. Cholecystokinin. Cholecystokinin have major three action. It cause gallbladder contraction. It stimulate pancreatic secretion. It inhibit gastric emptying. So answer is cholecystokinin. When pancreatic cells are stimulated, they will secrete what? When pancreatic cell, simply question is that pancreatic cell will secrete what? What is released by pancreatic cell? What is released by pancreatic cell? What is released by pancreatic cell? Tell me. HCl and bicarbonate. There are two cells. One is chief cell, other is parietal cell. Parietal cell is also called as oxyntic cell. Oxyntic cell. Chief cell form pepsinogen. Pepsinogen, CEO of Pepsi company. Parietal cell or oxyntic cell form HCl and intrinsic factor of Kessel. So answer is A. And that is why if antibodies are against parietal cell, that is why if antibodies are against parietal cell, intrinsic factor will not be caused and we will have megaloblastic anemia, that is called as pernicious anemia. That is called as pernicious anemia. When antibodies are against parietal cell, it will cause pernicious anemia because parietal cell secrete HCl and intrinsic factor of Kessel. Intrinsic factor of Kessel cause absorption of vitamin B12. If B12 is not absorbed, it will cause megaloblastic anemia, and this is called as what? It is called as pernicious anemia. Okay. Welcome Paras Jain. After interval, some heroes are coming after interval. 26. Okay. A 44-year-old woman is diagnosed with Zollinger-Ellison syndrome. Which of the following is consistent with the diagnosis? ZE syndrome is what? What is ZE syndrome? ZE syndrome means there is gastrinoma. Gastrin is more of the gastrin. What is the answer? If there is gastrinoma in Zollinger-Ellison syndrome, there is more of the gastrin. Gastrin releases what? Decreased gastrin? No. Increased insulin. Gastrin releases which not hormone. What is increased by gastrin? What is the answer? It will increase HCl. It will increase HCl, and HCl will cause peptic ulcer disease. Yes, very good. Answer is C. Okay. So Zollinger-Ellison syndrome is gastrinoma. It will release more and more gastrin. Gastrin will stimulate more and more acid. Acid will cause peptic ulcer disease. Answer is C. Which of the following is the site of bile acid transport? Very simple. What is the answer? Which of the following is the site of sodium bile acid co-transport? Bile acid is absorbed from where? From where bile acid is absorbed? Bile and B12. Bile and B12 absorbed from ileum. Okay. Ferrous, iron absorbed from duodenum. Iron and calcium from duodenum. Rest all is absorbed from jejunum. So almost everything is absorbed from jejunum. Answer is jejunum. Only iron and calcium, bivalent ion from duodenum, and bile and B12 from ileum. Very simple to remember. Almost everything is reabsorbed from the jejunum. Answer is jejunum, except bile and B12 from ileum, calcium and iron from the duodenum. So answer will be what? Ileum. Ileum is for bile and B12. Ileum is for bile and vitamin B12. Clear? Which of the following autonomic drug act on adenyl cyclase? Adenyl cyclase activates cyclic AMP. Cyclic AMP means which receptor? G protein couple receptor. So which receptor is GPCR? Beta receptor. And which drug is acting on beta receptor? Norepinephrine. Okay. Yes, answer is D. Norepinephrine act on beta receptor. Which of the following is the step in photoreception in the rod? When light falls on the rod, what will happen? Which is the correct step for light falling on the which is the correct step of photoreception in the rod? Yes, we says A. Read carefully. Option, read carefully, my dear friend. If you remember the diagram which I have given in my notes, light convert cis into trans or trans into cis. It is opposite given, my dear. First is wrong. Cis into trans. Cis retinol is converted into trans retinol, which form protein called as transducin. Transducin is a phosphodiesterase which converts cyclic GMP into GMP. GMP become less and cell will hyperpolarize. Yes, Vises and Paras Jain. C. Why C? Cyclic GMP will increase or decrease? Okay. Cis is converted into trans by, I have given you mnemonic, Balma, BLM, the Shakti Kapoor dialogue, Balma. B is Bathmo-rhodopsin, convert into Lumi-rhodopsin, which convert into meta-rhodopsin 1, then meta-rhodopsin 2, which convert into transducin. So see, all options are close but opposite. Very beautiful question. I hope you remember the notes. Please keep on revising the notes, but it will not be helpful. Notes revision will not be helpful if you are not doing what? MCQ. Until you solve MCQ, no notes is going to help you. See, light converts cis into trans. It is wrong. Meta-rhodopsin activate transducin. Correct. Cyclic GMP is increase or decrease? Decrease. Rod depolarize? No. Rod will hyperpolarize. Am I clear? When light falls on the rod, cis is converted into trans through a cycle called as Watt cycle. Balma, Bathmo-rhodopsin into Lumi-rhodopsin into meta-rhodopsin 1 into meta-rhodopsin 2, which will activate transducin. Transducin is a phosphodiesterase which will convert cyclic GMP into GMP. Cyclic GMP channel will close. instead of depolarization, now there will be hyperpolarization. Clear? Pathogens that cause fever, pathogen that produce fever cause what? Decrease production of interleukin? No. Fever will produce more interleukin. Decrease set point? No. Increase set point. Shivering? Yes. Before fever you shiver. Vasodilation? No. Vasoconstriction. So answer is C. Now the last slide. I will take only 10 minutes more. Let me finish this also. Okay. I will not repeat the same question, same topic, but the questions will be repeated, of course. This question is which of the following statement is true about olfactory system? The receptor cells are neuron. Absolutely correct. They cross cribriform plate, not prepiriform plexus. These are ending in the olfactory bulb, and these are C fiber, not A beta fiber. Receptor cells are neuron. True. Receptor cells are sloughed off and not replaced. No. These receptors are continuously replaced. Remember, olfactory nerve is the receptor in the roof of the nose, and these are continuously replaced. It is false. Axon of cranial nerve or A delta? No, they are C fiber. They cross prepiriform plexus? No, they cross cribriform plexus. Cribriform plexus. So answer is A. Receptors are neuron. Absolutely correct. Okay, second question. A lesion of chorda tympani nerve will most likely result in. A lesion of chorda tympani nerve will result in. Chorda tympani take the taste from anterior two-third. So it is the taste, impaired taste. Chorda tympani is the taste. So answer will be impaired taste function. Which of the following would produce maximum excitation of the hair cell in right semicircular canal? Semicircular canal is for angular acceleration. When you are rotating your head, semicircular canal are for angular acceleration. Look carefully. When you are moving toward the right, right semicircular canal will work. If you move towards the left, left will work. So if someone is moving right, rotation of the head to the right will. So answer is D. Answer is what? D. Next question. Inability to perform rapid alternate movement. This is called as diadokinesia. If you cannot perform, this is called as dysdiadokinesia or adiadokinesia. And answer is what? What is the answer? You know, cerebellum. Which part of the cerebellum? Neocerebellum, paleo or archie? Paleo. The function of paleocerebellum is diadokinesia and to maintain muscle tone. So if there is a lesion of the cerebellum, we cannot do alternate movement. Answer is C. Yes, D. Why Hitansi it is D? Yes, Hitansi Agrawal, why it is D? Substantia nigra will cause Parkinson disease, na? It will cause Parkinson disease. When there is lesion of dopaminergic nigrostriatal pathway, it causes Parkinson disease. So answer is C, not D. Okay. Which of the following will cause decrease in the renal calcium clearance? I hope you remember the kidney. Which will cause decrease renal calcium clearance? You know, furosemide increase calcium clearance and thiazide decrease. In the Bartter also, see Bartter syndrome and loop diuretic. Both are increasing calcium clearance. But Gentleman syndrome and thiazide, they decrease calcium clearance, increase calcium absorption. So what is the answer? Treatment with thiazide. Furosemide will increase calcium clearance. Okay. Yes, Akshita, answer is B, correct. Next question. A patient arrives at the emergency room with pH of 7.69, bicarbonate this, carbon dioxide this. Which of the following will expect in the patient? What is this diagnosis? It is alkalosis, metabolic alkalosis with compensatory respiratory acidosis. And whenever there is metabolic alkalosis, it causes what? If compensatory respiratory acidosis, hyperventilation or hypoventilation? If there is compensatory respiratory acidosis, you are hyperventilating or hypoventilating? Carbon dioxide retention is there, so hypoventilating. And metabolic alkalosis always cause what? Hypokalemia. I have discussed so many times. Yes or no? Hypokalemia. How? By exchanging proton with the potassium. See, cells, whenever there is metabolic alkalosis, proton will be less. So proton will be less, it will get from the cell. And what will come? Potassium will come. So there will be hypokalemia. Why? Due to exchange of proton with the potassium by proton pump. Discussed so many times this concept. This question is discussed. Which of the following has highest renal clearance? Which has maximum renal clearance? 100% of renal plasma flow gone to the clearance. 100% of renal plasma flow. What is the answer? PAH. You know that answer is pH because it is used for measurement of renal plasma flow. Inulin is used for measurement of GFR. Glucose does not go outside. So answer is what? Why everyone is saying B? Answer is A. Inulin is equal to GFR. Only 20% of renal plasma flow. It is 100% of renal plasma flow. So answer is A, my dear, not B. Everyone is saying B. Paras Jain, Deepika Palak. So answer is A, para-aminohippuric acid. Para-aminohippuric acid, everything is filtered and whatever left is secreted. So clearance is 100%. That is why PAH is used to measure renal plasma flow. Next question. Which of the following will cause hyperkalemia? Which of the following will cause hyperkalemia? See, when we do exercise, cell will burst and potassium come outside. So exercise always cause hyperkalemia. Alkalosis, just now I have told you, alkalosis cause hypokalemia. Insulin cause influx of potassium in the cell. Insulin cause hypokalemia. So answer is A, exercise. Okay. Which volume remain in the lung after maximal expiration? After full expiration, what is left? Residual volume. Amount of air after full expiration is residual volume, and amount of air after normal expiration is functional residual capacity. If they ask you amount of air after normal expiration, answer is functional residual capacity. And if they ask you amount of air after full expiration, answer is residual volume. This is the same question. Compared with the apex of lung, the base of lung will have what? See, I have told you so many times, this is apex, this is base. Ventilation is maximum at the base. Perfusion is also maximum at the base. But V by Q ratio is maximum at the apex. That is why PO2 is highest at the apex and carbon dioxide is more at the base. So, what is the answer? Compared with the apex of lung, the base of lung will have high PO2? No. High PO2 in the apex. High PCO2? Yes. High V by Q? No. Low V by Q. Same V by Q? No. So, answer is high PCO2. Okay. Hypoxia causes hyperventilation by direct effect on. If you remember, peripheral chemoreceptor are of two type. Chemoreceptor are of two type. One is peripheral chemoreceptor, other is medullary or central chemoreceptor. Peripheral chemoreceptors are sensitive to hypoxia, hypercapnia and acidosis. Medullary chemoreceptors are only sensitive to hypercapnia. This is the common stimulus. So, who will be stimulated for hypoxia? Peripheral chemoreceptor. What are those? Carotid body and aortic body. Carotid body and aortic body. So, when there is hypoxia, it will be sensed by carotid body and aortic body, and you will do hyperventilation, and oxygen will come inside, and CO2 will be gone. So, you will feel better. Answer is D. This is from formula I have discussed already. Action potential. Increase ACTH secretion would be expected in which patient? ACTH will be more in which patient and why? Addison disease, primary adrenocortical hyperplasia, someone who is receiving glucocorticoid or with elevated level of angiotensin II. Who will have maximum ACTH? Who will have increased ACTH? What is the answer? What is the answer? Nimajit, very good. Answer is A. In Addison disease, cortisol is less, aldosterone is less, sex hormones are less. So, ACTH will be stimulated to increase what? The hormone. Negative feedback mechanism. If the cortisols are less, it will cause increase in ACTH. So, answer is Addison disease. Okay. Which of the following would be expected in the patient of grave disease? Grave disease, hyperthyroidism. Hyperthyroid patient feel more of the cold sensitive? No. Cold sensitive is in hypothyroid. Weight gain hypothyroid. Increased T3 level and decreased TSH. Grave disease is hyperthyroid. Just now we have discussed in the previous. What is the mechanism of peristalsis? What is the mechanism of? I will take 10 minutes more. It will be finished. What is the mechanism of peristalsis? Peristalsis, if there is bolus in at the back of food, there is contraction. At the front of food, there is relaxation. This will move the food. It is called as peristalsis. So, what is the answer? It involves contraction of the proximal segment behind the bolus and relaxation of the distal segment. So, food will move forward, and this is called as peristalsis. Answer is D. It involves contraction of the circular smooth muscle behind the food and relaxation of the circular muscle in front of the bolus. So, answer is D. The drug cimetidine is given for ulcer. Cimetidine, ranitidine, these are blocker of what? They are H2 blocker, antihistaminics. Which of the following has much lower concentration in CSF than in the blood? Which is less in the blood? Glucose and protein. Protein are less. Protein are less. Now, very important question. Which of the following would cause an increase in both GFR and renal plasma flow? In which condition both will increase? Dilation of the afferent arteriole, dilation of the efferent arteriole, hyperproteinemia, or ureteral stone. We will discuss 4 conditions. What is the answer? In which condition GFR and renal plasma flow both are more? Only one condition can be there. What is the answer? D. D is dilation of the efferent arteriole. Efferent arteriole GFR decreases, if you remember. Please see the notes. And renal plasma flow increases. Just open your notes and see in the kidney. We have discussed dilation of the efferent arteriole will decrease the GFR because of decreased hydrostatic pressure and increased plasma flow. Yes, dilation of the afferent arteriole. This will increase both. This will increase both GFR as well as renal plasma flow. This is right shift of the curve. What is the cause of right shift of the curve? What is the cause of right shift of the curve? Increased pH, decreased 2,3-DPG, strenuous exercise, or fetal hemoglobin. Right shift of the curve happen in which condition? Alkalosis, left shift. What is the answer? A. A is alkalosis, my dear. Alkalosis will cause left shift. And this is right shift. From A to B is the right shift. Decreased 2,3-DPG will again cause left shift. Exercise will need more oxygen. Exercise, acidosis, increased 2,3-DPG. See, exercise, acidosis, increased 2,3-DPG, increase 50, P50 will cause right shift. Okay. So, answer is C, strenuous exercise. The last, no, not last, second last question. A 49-year-old man has pulmonary embolism. As a result of this, what is the correct answer? Which is the correct answer of pulmonary embolism? If there is pulmonary embolism, there is no blood circulation. What is the correct answer? Pulmonary embolism is also called as, if you remember the notes, alveolar dead space. What is the answer? See, if there is no blood here, oxygen will not be transported. So, in this condition, if you remember, we have discussed alveolar pressure of oxygen will be equal to inspired oxygen. PaO2 will be equal to PiO2. And V by Q ratio, air is there, blood is not there, will be infinite, not 0. It is 0? No. V by Q is lower? No, it is infinite. Alveolar PO2 in the left lung will be equal to PO2 in the inspired air. We will discuss in detail. It is 1 hour. It is 1 hour topic which we have discussed in detail in V by Q ratio. Just go to the app, or if you know her notes, just see the notes. Now, the last question, curve shift from A to B. Again, right shift of the curve will happen in which option? Which option is telling you right shift? I have already discussed. Right shift of the curve. Right shift of the curve, increase P50, increase affinity, increase unloading or increase oxygen capacity. Just now we have discussed. Right shift of the curve. Yes, very good. Just now we have discussed increase P50. Increase P50 or increase acidosis or decrease pH or exercise. All these will cause right shift. So by this I will stop here. Already it is 10:40. So by now we have discussed 90 question. I hope this much is clear. Any doubt you can ask me or else I can stop it. So okay, thank you. Good night everyone. Study hard. For any doubt, please ask me. I will try to answer that question. So thanks a lot. Good night.